And we are ready whenever you are.
I'm ready. This is going to be a different presentation from the previous. I think that I was given the opportunity by the USTMA leadership to just tell stories. You're tired after a full day, and I think I can maybe provide some entertainment. So my title is The Golden Rule for Doctors, and this is where we learn so much. Sometimes it's not as simple as having a hypothesis. It doesn't follow the outline that Dr. Lyles outlined, but you learn from your patients, as Dee Terrell just said. Next slide. So I'll go through the story of how all this started with the Oklahoma TTP registry. The key is that we have to learn how to recognize unexpected opportunities. We never started out to begin a registry. I didn't know what a registry was, but listening to patients, listening to my colleagues, we learned how to do this. Next slide. So we'll begin at the beginning. This is 1990, 30 years ago. I just moved to Oklahoma. I was beginning a new career as the chief of hematology and oncology at the university. And part of what I did the first year was just meet the community physicians, the hematologists-oncologists, and trying to set up the university and the community as a cooperative group. Part of my visits around the city went to the Oklahoma Blood Institute across the street. I was familiar with blood centers in hospitals that did donations, prepared blood, supplied the blood, but this was different than anything I had known. The OBI collects the blood from most of the state of Oklahoma. We learned subsequently 58 out of the 77 counties. The OBI also does all of the plasma exchange procedures. That didn't mean anything to me at the time, but in the next slide, next there. In August of 1991 is when the world changed for TTP. This was the publication in the New England Journal of the Canadian randomized trial of plasma exchange. In the era when I grew up, essentially everybody with TTP died. There was no effective treatment. Plasma was beginning to be an effective treatment in the 1970s. In the 1980s, plasma exchange became possible. And what Canada did is randomize patients to be treated with just plasma infusion or plasma exchange, and the results were striking. 78% of their patients survived. Just to put our current patients more at ease, I'd say the current survival is more like 95%. The problem was in 1991, there was no diagnostic test for TTP. So doctors thought that anything with severe thrombocytopenia, hemolytic anemia, some other symptoms could be TTP, and now there was a treatment. It's like the old story that you hear, the man with a hammer, everything looks like a nail. Here we had a treatment for TTP, everything looked like TTP, and the requests for plasma exchange surged. In 5 years, going from just 4 per year to 33. Next slide. So what I did with one of our fellows at OU was to try and learn what plasma exchange can do, who should receive plasma exchange, how long we should continue plasma exchange, who actually has TTP. In the process, I became the resource for our community hematologists-oncologists. They mostly deal with cancer, maybe 85% of their time, So I was a helper, not a competitor, and I began to see all of the patients for whom plasma exchange was requested for suspected TTP as part of the project that Maez had, simply to understand who would benefit from plasma exchange. Next slide. As Dee just mentioned recently, the previous program, it was one of my patients who I was seeing in clinic. She was a home health nurse. She had recovered, and she told me she didn't have the energy or the endurance to do what she needed to do. She used to see 12 patients in a day. She said now she can never see more than 5 or 6. So I did what I told you the golden rule is. I listened to her, I tried to learn from her, and I told her that this wasn't related to TTP, because TTP is an acute disease. You get over it, you're done with it, and I told her to just kind of stiffen up a little bit, it would go away. She told me that I needed to start a support group. I told her that was a really bad idea because different from other disorders, take breast cancer, for example, TTP was very different patient to patient. I said, you're going to hear a lot of stories that are different. You're going to feel worse when you leave this group. And I told her we shouldn't start a group. Another thing happened that year in 1995. A colleague asked me, are you collecting serum samples from your patient? I said, I'd never thought about serum samples. I said, why should we do that? He said, well, you never know. That was good enough for me, and it was easy for the OBI to collect serum samples because they were already collecting samples for HIV, for hepatitis, and it was one more tube for us to put in a freezer for whatever might happen in the future. Next slide. Here you can see that my patient 1, that was the way it should be. And I conceded. And in September 1996, we had our first patient support group. There are 14 patients there. I was impressed and surprised about how many people came. I was even more surprised that most patients, not all, but most, described these same symptoms of memory, endurance problems, and the fact that they didn't seem the same as they were before. Well, I told them what I told my patient, that TTP is an acute disease. There's no descriptions published of any chronic symptoms following TTP. And then one of the men, a recovered TTP patient, said to me, and I can picture him, he was sitting toward the back on the right side. He said, Dr. George, we have a project for you. You have to write about us. Well, I have written about them, but it took several years after this before it even started. Next slide. Here's what happened with the support group, just looking ahead, the first 20 years, and then it continues. So it was amazing to me, the motivation of these patients and then their family members also, as you can see in the hatched bars. Month after month, year after year, except this one time when there was an ice storm in 2010, they came and we learned an enormous amount from the patients. Next slide. 1997 was a key year. This is in the category of listening to your friends and not thinking that you have all the good ideas, but sometimes you don't even recognize ideas that are right in front of you. Gary Raskob was in the office next to me in the basement of the hospital. He's an epidemiologist. He's currently dean of our College of Public Health. he said to me that you have an inception cohort of patients. I had no clue what an inception cohort was. He said, because the OBI does all of the plasma exchange in this region, you have all of the patients, consecutive patients, identified at the beginning of their illness. Because if a doctor suspects TTP, there was just one phone number to call. There was no bias. There was no selection of patients. There was no referral of patients. This was everything within a defined geographic region. He told me this is a registry. He said it's a capital R. You need to know about registries. And then he said he had a PhD student, Sara Vesely, who was looking for an opportunity for her PhD dissertation. She wanted a small group of patients that she could use to predict future use, which small groups can lead to a large randomized trial, as Dr. Lyles talked about. So Sara came over to our office in the basement where Maez and I had kept all of our files, and she wanted to see what our patients looked like. We had not quite 100 at this time. So she looked at the forms and she said, "Where is your case report form?" I said, "Sara, I'm a doctor. We write these reports of our patients. We write the history, we write the physical exam. This is what's in the file." She said, "No, that's not acceptable." She said, "You have to have a case report form where you're asking the same questions to all the patients so you can have consistent data." Okay, so I said, "That sounds good to me, Sara, we'll do that." And then she looked and she said, "Where are the consent forms?" I said, "Sara, I'm a doctor." I said, "I see patients in the hospital. They do all this stuff down in the front office when they come into the hospital. I don't do consent forms." Sara said, "This is research. This is something that may be published. You need consent forms." I conceded a second time, and I conceded a third time when she asked about database. I knew nothing about computers. I knew nothing about Microsoft Access, and Sara then had she didn't just have a project here. She didn't just have a dissertation. She had a career. Next slide. Each year brings something new. This was a huge publication. It was 2 publications back to back in the New England Journal in November of 1998. They described the absence of ADAMTS13. It wasn't named that yet. It was called vulmogram factor cleaving protease, but it was absent or severely deficient in patients with TTP. In most of the patients, they identified an antibody type protein that inhibited the function. You know this now as acquired TTP. In some patients, there was no inhibitor, particularly 2 brothers in Switzerland, and they had hereditary TTP. The group in Switzerland was led by Bernard Lemley, who became a colleague of ours. At this time, we were really excited that we had the opportunity to know who did and who did not have TTP, but we had no way to measure the ADAMTS13. Next slide. Well, here we're back to Dee Terrell. You just met Dee Terrell. She just finished her training. She had worked at the state health department for 2 years. The registry was growing. She was looking for a position to come back and work at OU. We were needing somebody like this. And I said to Dee, "What would you like to do with us?" And she said, "I'd like to work on a project that involves racial disparities." I said, "That's a valuable goal, but TTP," I said, "has no racial disparities. If you work with us, you'll just have to work with all of our patients." And she agreed that in spite of this, this was a good opportunity for her. Next slide. That same time that I was talking to Dee, she had been recommended by Sara Vesely. Sara was at a meeting presenting our initial experience with what we'd learned from our first 100 patients. We didn't have ADAMTS13. We didn't have identification of the TTP patients, but what we did have, we had a distribution of our patients, some that looked like TTP, some associated with pregnancy, and et cetera. When Sara was presenting our experience, another person on the program, Bernhard Lemley from Switzerland, was also participating. Sara and Bernhard talked after their meeting. Sara said, we have this patient registry. See, we were calling it a registry now. I'd learned this. But we have no way to measure ADAMTS13. Bernhard said, we measure ADAMTS13, but we have no patient group for which to test the accuracy of our measurement. Well, what do you think happened from that? Next slide. 2003 was our first publication together with Bernhard and his team. We had not 42 patients, we had 142 patients. We're missing the first number on the top line. That began in 1995 when we began collecting the serum samples for which I didn't know the value up through December of 2001. 18 patients, 13%, had undetectable ADAMTS13. Can you go back there? It was less than 5%. That was as low as Bernhard's laboratory could measure. And we felt that each of those 18 patients had all of the characteristic clinical features of TTP. And then we were stunned by who these patients were. 14 were women. Well, that's held up in every study since, that about 75% of patients with acquired TTP are women. The median age was 38. Very rare in children. The youngest was 19. Rare in the elderly. The oldest was 71. And here was where Dee Terrell got what she was asking for. There was this enormous racial disparity. Half of our patients were Black. It hasn't always trended this way, but subsequent studies, we were able to show that the relative frequency among Black Americans in our population was 7-fold what the expected frequency would be. And then if we looked at the next level of ADAMTS13, 5 to 9%, there were 2 patients who I felt clearly did not have TTP. One man had sepsis. He was stopped plasma exchange. He got antibiotics. He was well. Another young woman had severe liver failure and was in the ICU and died. She had an autopsy and no evidence of TTP. So we thought that up to 10% was better sensitivity. We found 6 more patients, but it wasn't as specific as before. But we used then, from then on, the level of less than 10% as our diagnosis of TTP, knowing that we'll overestimate some and we may miss a few. Next slide. Now that we could measure TTP on our patients, we did what we subsequently called summer studies. Dee Terrell and a colleague, Jed Perdue, a student with us, saw our patients who we had confirmed with ADAMTS13 deficiency. Here, the first time, 8 years later, after our support group, we were using a inquiry, a questionnaire for cognitive function to confirm what we had learned for our patients. Now, we wanted to do a control arm for this too. And for a control arm, we used a questionnaire for depression because patients with depression can also often seem slow to respond and act as if they actually had cognitive impairment. And as with laboratory experiments and any research, you learn as much from your control group as you do from your experimental group. Both groups, both questionnaires, the patients failed to meet the normal values. They weren't abnormal. They didn't have significant cognitive impairment, but they were clustered in the lower range. In the depression scale, some patients had severe depression previously undiagnosed. Some patients had moderate depression. So this began a long series of experiments with our patients to try to understand this. And you just heard from Dee Terrell minutes ago that these experiments, these questionnaires, this investigation continues. We also measured ADAMTS13 activity because this was something we wanted to follow. It was something that was easy for us to put into our annual shipments to Switzerland for Bernhard Lemley, his successor, Johanna Kremer. We assumed since our patients were normal, the ADAMTS13 would be normal. Again, we had a great surprise. Most of our patients were normal or near normal. Not most were in the normal range, but they were close. But some of our patients had severe deficiencies of ADAMTS13. We had no idea what was happening. Other patients were 20% or 30%. One young woman had undetectable ADAMTS13 that summer, and many subsequent summers never relapsed. Now we use this as a marker for potential relapse, but maybe, as Dr. Catalan has shown, may not be the only marker. Next slide. So here's what we know a little bit about in 2020. This is what Dee is doing currently, looking for the issues that make TTP not an acute disease with recovery, but a continuing lifelong disease with exacerbations, or maybe without exacerbation, minor cognitive impairment, depression, albuminuria, hypertension, occurrence of other autoimmune diseases. With the new treatments that are available, we have the opportunity to study that. And it may be in the future that plasma exchange, which started all this, may not be necessary. Next slide. Something I learned in medical school, and something that we all learn, is called shared decision-making. And I took this from an article that was in the Journal of the American Medical Association last year. All physicians know about shared decision-making, respectful and responsive, and patient values. The actual integration into clinical practice rarely occurs, but I want to show you an example of how this works. Next slide. These are my friends at Ohio State. I think the USTMA is familiar with people who work at Ohio State University. This is a story about a patient who was seen there just about a year ago, maybe not quite a year ago. She was a middle-aged woman. I'd call her a young woman. She had a 10-year history of multiple relapses of TTP. She was coming back to see Dr. Catalan for a routine 3-month follow-up visit. She'd had 4 days of minor symptoms, not enough for her to see her primary care physician, not enough for her to call and see Dr. Catalan sooner. But her platelet count was low, not dangerously low, but lower than it was 3 months before. Hemoglobin was normal, and the peripheral blood smear had these fragmented red cells, which are the classic feature of the hemolysis of TTP. Dr. Catalan assumed a relapse, and then a conversation began. Next slide. This patient was very familiar with TTP. She knew the drill. She knew about going into the hospital. She knew about getting a central venous catheter. She knew all of this, but she wasn't sick. She said to Spiro, do I have to go in the hospital? Do I need that catheter and that plasma treatment? Do I need steroids? She said, I hate steroids. For the patients listening now, I'm sure that rings true. Everybody hates steroids. And then Dr. Catalan thinks. She knows her disease. She's not critically ill. Her current platelet count is safe. She lives close and her family is very supportive. And he describes caplacizumab. Next slide. So that day she received her first dose of caplacizumab. They agreed that it wasn't necessary for her to go in the hospital. They agreed that they didn't need to start steroids on this day. The next day she comes back and her ADAMTS13 is predictably low. Her platelet count is already up from 86 to 112. On the following day, it's normal at 159. In these 3 days, she gets her caplacizumab in the clinic and learns how to inject herself at home. So there's this gap from day 3 to day 6. So if you're very acute, you can figure out that this is probably a Saturday and a Sunday, and Monday she comes back to see Dr. Catalan. Her symptoms are resolved. She begins weekly rituximab. Since caplacizumab is just not a definitive treatment, doesn't do anything to the autoimmune etiology, but just blocks the platelet binding to von Willebrand factor and blocks the occurrence of thrombosis. So she started rituximab. She got weekly rituximab for 4 doses. It took longer than those 4 doses for the ADAMTS13 to recover. This is what I would say is the perfect example of shared decision-making. It's the perfect example of how we can talk to our patients and learn from our patients. Next slide. Those are my stories. We're up to date. There's now been 3 other reports of using rituximab and caplacizumab with 5 patients, and we're standing by to see what the future of that is. I think I kept my time. Claire, did I keep my time?
You did absolutely perfect, actually. So that was great. We really
that's what rehearsal does.
There you go. You did it perfectly. We really appreciate you coming and talking with us. And
I didn't have to come far, Claire.
You know, it wasn't difficult, right? Well, you definitely learned some new skills with Zoom, so we appreciate it. Thank you very much.
Thank you, Claire.
All right, and now I'm going to bring back Dr. Marshall Mazeppa, and Spiro Cadlin, and we're going to just finish up with closing statements.
Great. Well, I think this is the perfect way to end a great day of education on TTP and where things are going with the disease. It's such a huge honor to have Dr. George join us. I think all of us have recognized his leadership in this disease, and hope we can live up to his accomplishments, and hopefully we can take the baton forward to continue to improve our patients' lives. So thanks again, Dr. George, we really appreciate it. And thanks to everyone who joined us today. We hope that you have enjoyed it, and I'm grateful to all our colleagues who took some time out of their Saturday to meet with everyone. you know, our plan moving forward is to have this on an annual basis. And of course, hopefully next time this will be in person. And I think just like Dr. George was so insightful in engaging with patients there in Oklahoma, that we can carry that torch forward too and engage with patients from all over to continue to make improvements in everyone's lives. I'll let Dr. Cataland say a few words too before we wrap up.
No, I just want to thank everybody, patients for putting in their time, for all the people involved, in the speakers, the panelists, a volunteer grassroots effort to really put on a good program, and I think helped a lot of people. And a lot of thanks to Claire, who really pulled this thing together. Couldn't have done it without Claire and everybody else's involvement. We really hope we can do this in Chapel Hill next year. I guarantee you it's a beautiful setting. It was our first setting for our first research meeting now 4 or 5 years ago, and we want to go nowhere else but there. So it's a great venue. Really want to thank everybody for being involved, their contributions, and for all we're going to do going forward.
Yeah, thank you everybody for joining. Thank you for all our panelists. Thank you for the patients. When you close out of the Zoom meeting, there will be the option to go to a feedback survey for us. We would really, really love it if you could fill that out for us, just so we can make sure that we meet all the needs. And in the next 2 months or so, we're going to plan another Ask the Hematologist connection meeting. It's going to be on a smaller scale, with about 4 panelists, and it's going to be on our Facebook as well as through Zoom. So keep your eye out for that. And thank you so much for joining us today. Goodbye.
Thanks, everyone.
Take care.